which I was just talking about, if the depth of invasion is more than 10 mm or more, it is called as T3, and we do give adjuvant radiotherapy in oral cavity cancers. That we all agree to it. So till now, what we have learned is that the high risk features, they need chemotherapy along with radiation. And what are the high risk features? They are microscopic positive margins or positive margin, or extracapsular extensions, or the other factors like locally advanced disease, that is stage 3 and stage 4, and other factors like LVSI and PNI. But this is not the only scenario what we get in our OPD. What is the most common scenario what we find in our OPD is that whether the patient is T1N1 or whether the patient is T2N1 or whether the patient is T3N1 or whether the patient is T4N0, T4N1. This is the most common scenario. So what should be done? We all know if it is T3, T4, there is no doubt we have to give radiation. There is no doubt. We have already mentioned that, and that has also been shown in the Bernier and Cooper trial. Not only the radiation, but even chemotherapy was also added. But the question is that T1N1 and T2N1, what should be done? So the evidence comes from the SEER database, nearly almost 20 years, 1983 to 2004, and again from 2004 to 2013, nearly 30 years of SEER database had been looked into, and what they looked is that the DFS and OS, this was only for T1N1 and T2N1, and what did they find was that whether it is T1N1 or whether it is T2N1, adding radiation as an adjuvant in the adjuvant setting definitely has an advantage in the terms of disease-specific survival as well as overall survival. But what is even more important to note over here is that T2N1, the benefit, the magnitude of benefit is much higher as compared to the magnitude of benefit what we see in the T1N1. So T2N1 and T1N1 are benefited, but the benefit is more in the T2N1 as compared to T1N1. So adjuvant RT is independently associated with a significant survival benefit with both T1N1 and T2N1, but the benefit is more in T2N1 as compared to T1N1. Now, there are certain other adverse features, and that will also decide that what should be my adjuvant treatment, whether it is post-operative radiation alone or whether it is radiation along with chemotherapy. And in this we not only take that on what is the primary, that is T size, but we also look into that what is my nodal status, because nodal status is also an adverse feature which we will take into account, and I'll be coming into my next slide that what do we mean by nodal status. So depth of invasion is very, very important, and it's a very important prognostic factor. But apart from that, there are other factors which should be considered. And what is that particular factor? That particular factor is LVSI, that is lymphovascular invasion, or LVI. Now, why is LVI important? There are multiple papers to support that why LVI is a prognostic factor to decide upon adjuvant treatment. Because if there is an LVI positive, it indicates that cancer cells have invaded the nearby blood vessels and lymphatic channels, and thereby it signifies that the high likelihood of the tumor to spread into the lymph node. So the lymph nodal metastasis will be high if there is a LVI positive. And because of this association, LVI should be considered in deciding that what should be my optimal treatment plan and whether radiation should be given or not. So LVI is an independent prognostic factor to decide upon that whether adjuvant treatment has to be given or not. Apart from that, moving from LVI to PNI. Now again, PNI is nothing but it is defined as perineural invasion is defined that tumor is in close proximity to the nerve, and at least it involves 1/3 of its circumference, and it can involve either all or any particular layers of the nerve sheath. And this is the definition.
This is important.
But at the same time, the PNI can be perineural, it can be intraneural. Peri means it just across the periphery, or it goes inside the nerve, that is called as intraneural. PNI is again very very important because it itself it has a prognostic significance, because PNI patients have a tendency to have a locally advanced and have a chances of disease recurrence more as compared to PNI negative. Hence, PNI is extremely important. If we look at the meta-analysis which has been just published this year, PNI, we know that it's infiltrations of the cancer cells into the peripheral nerves. It is an important prognostic and independent prognostic factors as far as oral cavity squamous cell carcinoma is concerned. And if PNI is positive, you have a worse survival, you have a high chances of tumor relapse, both loco-regionally as well as distantly. And as a radiation oncologist, if the PNIs are positive, even the contouring becomes different. You are more liberal, you trace the nerve till the base of the skull. Even your doses can be different. So PNI is definitely a very important prognostic factor, not only to decide upon the treatment, but also the contouring and also the doses. So PNI, hence it's very important. So let's summarize the PNI. PNI is correlated with the nodal status and T stage, because high T stage and more number of nodes positive will have a chances of having a PNI also a positive. It will have an impact on disease-free survival, and the PNI can be subcategorized into intratumoral, that is inside the tumor, peripheral, that is only in the periphery, and extratumoral, that is outside the tumor. All the three. And if we give radiation, then the chances of having a control is better. But again, it has been said that if extratumoral PNI, that is PNI outside the tumor, is a definitely a worse prognostic group as compared to intratumoral and peripheral. So as a whole, PNI is bad. In that also, the extratumoral PNI is a worse, we can say. Now, beyond extranodal extension, what about the number of lymph node? This is the more contentious issue, that what should be the number of lymph node where we should give chemotherapy, we should be adding chemotherapy to radiation. And we don't have a very clear-cut answer to this, though this paper was published almost 5 years back, where quantitative lymph node burden as a very high risk factors was included. And what it was seen that if the patient is having just one lymph node, he might not be really having a benefit for adding chemotherapy. So between 0 to 2 lymph node without any extranodal extension, it might not be beneficial to add chemotherapy to radiation. So mind it, 0 to 2 lymph nodes without extranodal extension, without any positive, it might not be really beneficial to add chemotherapy. However, the benefit can be seen if there are 3 or more than 3 to 5 or more than 6 lymph node. So then the benefit becomes incremental if you add chemotherapy to radiation. So increasing the metastatic nodal burden was associated with increased survival impact, and these are the patients who will be benefiting from chemotherapy if it is being added to radiation versus post-operative radiation alone. But what's important to remember, 0 to 2 lymph node without extranodal extension might not be an ideal candidate to add chemotherapy to radiation. So if you move beyond extranodal extension, that is, I'm talking about the number of lymph nodes being positive. Again, what we have to remember is that this particular paper is very often quoted. And even if you don't remember the paper, no need to remember, but despite every meeting, every adjuvant treatment, if presentation happens, this paper, Trifility paper, which is published in JCO, despite being a retrospective series, this is the most common quoted paper. And what it was seen that if the patients are having no nodes involved, or just one node involved, or if there's a 2 to 4 lymph node involved, or if it is more than 5 lymph node involved,
Sorry.
if the number of lymph nodes increases, now these are the patients who will be benefiting from adding chemotherapy to radiation. So the more the number of lymph nodes involved, more is the benefit of chemotherapy added to radiation. But what is the ideal number of lymph node which will decide that this patient should be given chemotherapy? We don't have answer to that. So I cannot say, okay, more than 4 you have to give chemotherapy, or more than 5 you have to give chemotherapy. But one thing we definitely say, that as the number of lymph node will increase, the percentage of benefit of adding chemotherapy to radiation is definitely more. Now, this is something again which all radiation oncologists has to look into it, that apart from depth of invasion, there is something called as tumor budding and worst pattern of invasion, that is WPOI, and this other terminology also called as PPOI, that is predominant pattern of invasion. So these three factors also has to be taken into account: depth of invasion, tumor budding, and worst pattern of invasion. Now, on a multivariate analysis, if the depth of invasion is more than 4 mm, tumor budding more than 5 cells at the invasive front, that is upfront, and so these are the patients where it will be useful to see that these patients will be requiring adjuvant treatment, and also, if necessary, treatment intensification. I hope I am not confusing, but being a radiation oncologist, I will not have to only look at that what is the T3 or T4, what is the N1, N2, N3, what is the ENE, what is the LBI, what is PNI. I have to also look into what is the tumor budding and what is the worst pattern of invasion. These are definitely a minor factors, but that also has to be kept in mind to decide upon the adjuvant treatment. If we look at the risk tailored approach, like how to decide that what treatment I have to give. So if you look oral cavity squamous cell carcinoma, high risk features will be margin positive and extranodal extension or extracapsular extension positive. According to the Bernier and Cooper trial combined, these are the high risk features, and these are the patients where the treatment will be chemotherapy added to radiation. And this evidence comes from the Bernier and Cooper that margin positive and extranodal or extracapsular extension positive will be beneficial to add chemotherapy along with radiation in the adjuvant setting. Coming on to the intermediate risk features. Intermediate risk features, what I just told, that it can also be called as a minor features. So here the locally advanced disease, that is T3, T4, the LVI positives, the PNI positives, the close margin we can say less than 5 mm margin. These are the patients who definitely require adjuvant radiotherapy. Now the question will be that whether chemotherapy will be added or not. It becomes a, because we have a paper, just a triphility paper, which is again a retrospective series, but that says that if the number of lymph nodes are more, then the patients can be offered radiation, but otherwise adjuvant radiotherapy also is good enough. Then there are something called as low risk features, like where T1 and T2, where and nodes negative, we don't have uh, no adjuvant treatment will be required, and just surgery alone will be enough. And this is these are the patients who will be having the best outcome. Now, my presentation as such is over. Let's see some clinical scenarios like what we should do. A 66-year-old gentleman who has undergone a tongue surgery, that is hemiglossectomy, and then after undergoing a hemiglossectomy along with SLND, the histopathology is 2 into 1 into 1.3, that is basically by this it is T1, but the depth of invasion is 1.3, so it becomes, by criteria of depth of invasion, it will become T3. The histopathology comes as moderately differentiated squamous cell carcinoma. Margin 8 am is the closest margin, that is we can say is an adequate margin. LVI negative, PNI positive, ENE negative. Worst pattern of invasion is 5. Nodes 1 by 35 positive. Now the question arises that what should be the adjuvant treatment in this particular case? So one thing which is clear, it's a T3 disease because depth of invasion is more than 10 mm, that is 1.3 centimeters. He will definitely need RT because one node is positive, and there is also PNI positive. Now the question is that whether systemic therapy has to be added or not. This is a real case. Our medical oncologist decided that no systemic therapy, as there is no positive margin and there is no extranodal extension. Only one lymph node was positive, and even the lymph node dissection was adequate because 35 lymph nodes were taken out. So, despite that PNI is an independent prognostic factor, adjuvant radiotherapy alone will be good enough in this particular patient, and chemotherapy can be avoided. Now, if you look at the next case, again 54 years old lady, she presented with a growth in the right buccal mucosa, which was 2 into 3 centimeters. It was progressively increasing in size. Clinically, it was a T2N0. Biopsy was positive. Other metastatic workups where there was no distant spread and the disease was loco-regional confined. Patient had undergone surgery and the histopathology came as a moderately differentiated squamous cell carcinoma. The tumor size was 4.1. The depth is 12 mm, LVI negative and PNI negative. So you remember in the
इसको
first
लगेगा ना।
second slide I did say if the tumor size is more than 4 mm and if the depth of the depth is more than 12 mm or more than 10 mm, then these are the patients who will be called as T4A. LVI and PNI are negative, margins are free. 5 lymph nodes were positive, extranodal extension positive. So finally it was PT4A N3B. N3B also I did say that if it is more than N1, N2, N3 and if it is ENA positive, straight away it will go to N3B. So 5 lymph node positive. Now what should be the adjuvant treatment? In this
मुझे
particular patient,
स्टार्टिंग वाले
the
थोड़े पेज
patient will
दिखाई।
be given not only radiation, but apart from that radiation, yes, and concurrent chemotherapy also, yes, because the ENA is positive and 5 lymph nodes are positive. So, despite having an adequate surgery, still the patient will be requiring both chemotherapy as well as radiation. Now, let us see the other case. 70 years old
ये तुम्हारे नए
lady.
जूनियर्स आ गए क्या?
This was the lesion in the tongue on the left lateral aspect. It was a confined and it was there from the last 2 months. There was no lymph node in the neck. Patient biopsy was positive for the tongue growth. Patient underwent wide local excision of the tongue along with left-sided neck dissection. This is a googly now because the tumor size is 2 into 2 into zero point 0.9. Depth of infiltration becomes 9 mm. The thickness and the depth of invasion is only 6 mm. So again, mind it, we are so much habituated that thickness and depth of invasion it becomes synonymous that we tend to interchange these two terminologies. But from today onwards, let us be very specific that thickness is different and DOI is different. So DOI was 6 mm, well differentiated squamous cell carcinoma. Margins were free. Predominant pattern of invasion and worst pattern of invasion both were 3. LV and PNI both were negative, and 37 lymph node dissected, all were negative. So in this, the question becomes that what should be the whether adjuvant treatment should be given or not. Now, this is a very common scenario in OPD because the tumor size is okay, it's a T1, but thickness is 9 mm. If suppose if this would have been more than 10 mm, then it would have become T3. There would have been no confusion. Radiation should have been given in this, but it becomes 9 mm. Depth of invasion is 6 mm.
तो थिकनेस से
WPI is only
कहाँ से
3.
डिसाइड हो गया
All
रे?
the lymph nodes are negative. Then what to
थिकनेस
do?
से कैसे
Really,
डिसाइड हो
the
गया?
answer
थिकनेस तो
here, the
आता ही नहीं है
answer is
स्टेजिंग
becomes
में।
difficult at what should be, and it should be a individualized call because in this particular situation, I will prefer to give radiation because the 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 depth of invasion is 6 mm. But at the same time, the other radiation oncologist might not, and we both can be right. We both can be right. So we don't have an answer to it. But how will you decide at what treatment should be given? It has to be seen that whether the in this kind of a situation, how do will you decide that whether adjuvant treatment has to be given or not? What is the age of the patient, gender of the patient, performance status of the patient? What is the grade, the depth of invasion, the margin status? If there is any dysplasia at the resection margin, what is your WPOI and PPOI? What is the PNI, LV, nodal status? All has to be carefully looked into. And also we should look, it's not only about the ENE, that is extranodal extension, but there is also called something like a micro ENE. like microscopically if there is any ENE was positive or not, which can just give you an idea that whether adjuvant treatment can be given or not. So with this, I'll be ending my presentation. And it was a short presentation purposefully so that we can discuss. Madam is also there as a moderator. Madam, in that case, since the patient has say that, if I understand the question, what is the importance of WPOI? Is that the question?
Yeah, WPOI and depth of.
In that case, PPOI, that is predominant pattern of invasion, and in conjunction with the depth of invasion. So WPOI independently, it will not decide upon my adjuvant treatment. It can be used as a minor factor to decide upon the treatment. Like example, if it becomes a borderline case, like the case which I just showed, in that, if you see, like if I just go back one slide back, so yeah, so if I see over here, in this particular patient, if WPOI would have been 5, this would become easier for me to decide whether adjuvant treatment has to be given or not. So the importance of WPOI is definitely, it is a prognostic factor in deciding the treatment, but it can never be a sole factor to decide that whether adjuvant treatment can be given or not. So simple to understand, it can aid me to decide upon a treatment. That is one. And if WPOI is high 5, these are the patients where the chances of locoregional relapse will be more. So you have to take WPOI in conjunction with something like WPI positive, LV positive, PNI positive. So other factors also has to be clubbed into it, and then only we can come to a conclusion that the WPOI is significant. But as a individual, it cannot be taken as a factor to decide upon the adjuvant treatment.
What is the significance of tumor budding?
So, tumor budding is something which is coming up now. The pathologists, some of the pathologists, they do mention. It is basically tumor budding. You have to understand is that it is also an independent prognostic marker, and it has to be along with the mode of invasion. Like the tumor budding, if you to explain, the tumor budding can be low intensity tumor budding. It can be a intermediate intensity tumor budding, and it can be a high intensity tumor budding. So tumor budding means that under the microscope they see how many buds